I, Namrata Ekka of PSLP second year. Today I am going to present my presentation on apraxia. In my first slide, introduction is there. Now, what is apraxia? Apraxia is an acquired disorder of learned, skilled, sequential motor movement that cannot be encountered for by elementary disturbance of strength, coordination, sensation, or lack of comprehension or attention. An apraxia is also known as inability to correctly perform learned skill movement. As you know that to deal with the environment, some type of motor systems are required. At least two type of major programs are required. That is intentional means when to move and parasic means how to move. Disorder of this how or parasic system are called apraxis. And these apraxis are divided into two main groups. One is limb apraxia and second is buccofacial apraxia. So the clinician uses apraxia to describe non-learned motor dysfunction including oculomotor movement, joint initiation and eyelid opening. They also use apraxia to describe skilled motor tasks that are dependent on visuospatial processing including optic, constructional and dressing apraxia. Apraxia correctly applies to conditions that are more clearly consistent with the definition of disturbance in learned skilled movement. In this slide, you can see the flowchart of parasic model are given. Here you can see there is two types of input. One is visual and next is verbal, and from both this visual and verbal the input moves to axon-semantic posterior parental and movement formulation left parental loop, and from these two axon semantic and movement formulas the input moves to motor programs left supplementary motor area, and by a corpus callosum it moves to motor program right supplementary motor area, and from left supplementary motor area the input moves to left corticospinal system, that is left primary motor cortex, and from right supplementary motor area it moves to right corticospinal system, that is right primary motor cortex. And here you can see the some difference are there, like from left corticospinal system the input moves to right limbic output, and from right corticospinal system the input moves to left limbic output. And in next slide there is a flowchart of pathophysiology, and here also there is two input. One is visual input and next is verbal input, and from visual input the input moves to axon semantic and movement formulas, but from verbal input the input moves to verbal semantic, then it goes to axon semantic and movement formulas. Then the axon semantic and movement formulas moves to motor program, that is left supplementary motor area, and via corpus callosum the input moves to motor program, that is right supplementary motor area, and from left supplementary motor area the input moves to left corticospinal system, left primary motor cortex, and from right supplementary motor area it moves to right corticospinal system, that is right primary motor cortex. And here you can see again the difference there is that left corticospinal system moves to right limbic output and right corticospinal system moves to left limbic output. So now let's view on the causes of apraxia. So number 1 is stroke, number 2 is corticobasal degeneration, third Pick's disease, fourth Alzheimer's disease, fifth progressive supranuclear palsy, sixth intracranial tumor, and seventh traumatic brain injury. So in this slide, examination of limb apraxia are given. To examine the limb apraxia, the first step is dominant upper extremity. In this, the first one is pantomime to verbal command. In this, A, transit action like comb hair, brush teeth, flip a coin, use a scissor, use a key, etc. And in B, intransic action means wave goodbye, give the peace sign, give the okay sign. And the second is imitation of gesture. In this, the examiner demonstrates the some action without naming that action and asks the patient to copy it. The third is gesture knowledge. The examiner demonstrates different action and asks the patient to identify the purpose and function and how well they were used. So in this slide, types of limb apraxia are given. In this slide, buccofacial apraxia is given. Inability to perform skilled action involving the lip, mouth, and tongue in the absence of paresis. It is commonly associated with damage in the left frontal operculum and insula. Now, how to test? Patient should be asked, show me how to blow a matchbox, drink through a straw, protrude your tongue, etc. Now, constructional apraxia. In this, patients with this disorder do not have difficulty making most type of skilled movement with their arm and hand. They have no trouble using object properly, imitating their use, or pretending to use them. The primary deficient in constructional apraxia appears to involve the ability to perceive and imagine geometrical relation. Besides tests of constructional apraxia, including drawing, overlapping, pentagons, a cube. In this slide, you can see that the example of constructional apraxia is given here. In this slide, dressing apraxia is given. It signifies the future of the impaired tactile and visuospatial coordination plus hemi-neglect rather than the loss of the ability to use tool, tested by asking the patient to wear a jacket with the sleeves. Lesion is in right parietal lobe. Giant apraxia, impaired ability to execute the highly practiced coordinated movement of the lower leg required for walking. People appears to be stuck to the floor. There is difficulty in initiating walking. There may be disassociation between giant and distal volitional movement. Lesion in the pathway originating in the mesial frontal cortex. In this slide, oculomotor apraxia is given. It is impaired ability to generate saccades on command. Although reflectively induced saccades and random saccades are normal. Here, what do you mean by saccades? Saccades mean it is a quick simultaneously movement of both eye between two or more phases of fixation in the same direction. And this abnormality is a part of Blind syndrome. So in the next slide, apraxia of eyelid opening is given. It is inability to open the eye voluntarily in the absence of ptosis. Patient has to thrust his head backward to attempt eyelid opening or open their lid manually. Occur with lesion of right hemisphere or bilateral hemispheric lesion. Also seen in disorder of extrapharyngomedial system. So now the symptoms of apraxia includes difficulty in straining syllables together in the appropriate order to make a word, minimal babbling during infancy, difficulty saying long or complex word, repeated attempt at pronunciation of word, speech inconsistencies such as being able to say a sound or word properly at certain time but not other, incorrect inflection or stresses on certain sound or word, excessive use of non-verbal form of communication, distorting of vowel sound, omitting consonant at the beginning and end of word, seeming to group or struggle to make word. Childhood apraxia of speech rarely occurs alone. It is often accompanied by other language or cognitive deficient which may cause limited vocabulary, grammatical problem with coordination and fine motor skill, difficulties chewing and swallowing, and clumsiness. So in this slide, diagnoses are given. There is not a single test or procedure that is used to diagnose childhood apraxia of speech. Diagnosis is complicated by the fact that speech language pathologists have different options about which symptoms indicate the condition. They may assess a patient's ability to repeat a word multiple times, or they may assess whether a person can recite a list of words that are increasingly more difficult, such as play, playful, playfully. A speech language pathologist may interact with a child to access which sound syllables and word the child is able to make and understand. When diagnosing apraxia, expert may look for the presence of other symptoms. For instance, they may look for weakness or difficulties with language comprehension. The pathologist will also examine the child's mouth, tongue, and face for any structural problem that might be causing apraxia symptoms. Both of these are indicative of other conditions, and their presence would help rule out apraxia. For people with possible acquired apraxia, an MRI of the brain may be useful to determine the extent and location of any brain damage. Are there treatment for apraxia of speech? There are various treatment approaches used for apraxia. How effective they are can vary from person to person. For the best result, apraxia treatment must be developed to meet a given individual's need. Most children with apraxia of speech benefit from meeting one-on-one with a speech language pathologist 3 to 5 times a week. They may also need to work with their parents or guardian to practice the skill they are developed. Therapy for childhood apraxia of speech aims to improve speech coordination. Exercise may include repeatedly practice the formation and pronunciation of speech and sound, practicing stringing together sound to make speech, working with rhymes or melodies, using multisensory approach such as watching in a mirror whilst trying to form word or touching the face whilst talking.
Try when? It's okay if you can't do it right. I just want to see you try. Good trying. I'm going to do it with you. When. Good one. My turn. When. Good for you. This clip shows a therapy strategy in which the clinician and the child say the word or phrase at the same time. Notice how he does better when he looks at the clinician. After he is fairly accurate, we move to imitation. This is harder for him, so we can either go back to saying the word together or, as you'll see in this clip, have him repeat the word while watching me mouth the word at the same time. Gestures and slowed rate are other cues used in this clip. Notice how slowly we move toward normal rate with continued practice. No way.
No way.
Good job, very good. Do you like to eat dirt?
Way.
Good trying, that was very good. Say, no way.
No way.
Good job. Do you like it when people pick on you?
No
way. In this next clip, we see the same child a couple of days later.
Thank you so much for your attention.